and it is Friday. This is the second time we're going to try this video out. We tried it before and the sound was a little funky, and I think it had to do with my headphones, so I apologize for that if it sounded like a robot when I was doing this before. And if you're on live, let me know how it sounds, because I can't tell, but I'm trying a different microphone this time, so hopefully it's better. My name is Julie Hirschberg. I am the owner, founder of Re+active Therapy and Wellness here in the Los Angeles area. And I get to share every week a little bit about what we're doing, what we're learning together. And I learn so much from you, my colleagues, and really excited to join uh, you today, really for my second time here, to chat about things in the world of dizziness. And again, if you're joining me live, if you can give me a thumbs up that it sounds okay, because we had sound problems earlier. I think it was the microphone for my headphones, but if not, I'd like to hear that it is not sounding okay. So give me a thumbs up if we're sounding okay. I appreciate it. And we're diving into all things dizziness. And a big part of this is I get really excited when we have a course coming up. And I'm diving into the literature, I'm talking to people, I'm reading things, and dizziness is one of those. And even last week, when I was looking at functional movement disorders and talking about functional movement disorders, I had people asking me about dizziness and 3PD. And so this week we've been talking about that. And our course, we're hosting our very first full day course. It's online, but it's a 1 day course on dizziness. And this is coming up August 28th. And with this course, it's led by Catherine and Jamie, two amazing neuro PTs with a lot of background in dizziness and vestibular disorders. And I've been talking to them about this approach, this positive spin on dizziness, and looking at dizziness in a little different way. And I think specifically for complex dizziness, something that's not really straightforward. And we see a lot of this in our practice. And I've definitely seen a shift towards a little bit more complexity in our cases in the last year. I'm really curious if there's other therapists on here. Have you seen that too? I wouldn't be surprised if many people have, even just due to the pandemic. So on Wednesday in our Instagram live, I talked about 3PD as functional dizziness and how it develops. And we have a diagram that kind of goes steps by step of how it might develop. So if you didn't catch that, I highly recommend it. And if you're looking to get all of the things that we do, by the way, every week, you can sign up for our email newsletter. Every Friday, I send out a little summary of all the videos and the resources and articles and all of that stuff that I talk about during the week. I put it all in a newsletter, all in one spot. It goes out on Fridays. If you're not a part of it, you should be a part of it. So that's what we talked about on Wednesday. And today I wanted to dive a little deeper into the differential diagnosis of dizziness. Like, how do we know it's 3PD and not something else? And actually what I would say, it's often more than one thing. And so how do we know which layers of dizziness that we have? So we're going to talk today what's the latest in our understanding of the dizziness differential diagnosis, including a great article. I printed out one of my favorite pieces of it, which is this little algorithm, and I want to go through that today. And then thank you to Catherine and Jamie, the two people teaching our 1 day course, how to really understand the contribution from the underlying anatomy. So it's one thing to have a diagnosis, but if we haven't pinpointed where the dysfunction is from the anatomy and physiology standpoint, we can't treat it. So how to understand that and how having that right diagnosis and the anatomy leads right into treatment. So that's what we're going to dive into today. Let's go. So let's start with a broad overview of differential diagnosis in complex dizziness. And I think the first thing that we need to think about is what is our framework here? When it comes to dizziness, we can think of a couple of things. First, is it dizziness due to something gone awry in our vestibular system? Either the inner ear, the nerve, or all those pathways through the brainstem, spinal cord, into the brain and cerebellum that help us control our balance and sense of stability with our gaze. That's one thing. Is it vestibular or not? So there are things that are non-vestibular, our cardiovascular system, medications that affect these systems. These things are non-vestibular and we have to screen those as well. That's why when you come to see me, I'm always checking everybody's blood pressure, everybody's heart rate, right? So that's our first step in that differential diagnosis, is to really know, is it a vestibular issue or is it not a vestibular issue? Then a lot of times our vestibular system is involved, and some things are very easy to rule in and rule out. So in the vestibular category, we look at peripheral or central. Peripheral are that the inner ear, our vestibular apparatus, the nerve itself, and these are things like our benign paroxysmal positional vertigo, or BPPV. So very simple to hear somebody's story, head right down there, test it, treat it, boom. So it might be BPPV. It might be a vestibular hypofunction. So maybe somebody, if you're like me and you've had an infection that affected the vestibular nerve, those are all in the peripheral category. Meniere's disease fits in that peripheral category. Honestly, those are a little more straightforward in the vestibular system. I got to be honest. When we get to the central category, meaning the brain, the brainstem, the cerebellum, and all those connections between them, things get a little bit harder. So this is pieces like we might see after a brain injury or concussion, after a stroke, with MS, tumors in those particular areas can cause central dysfunction. Functional dizziness is a central dysfunction. It's connectivity in some of those central areas. Migraine, mal de débarquement would be another one. I would even argue our cervicogenic dizziness, so it's coming from the neck and the neck proprioception, which is peripheral. It's how the brain is interpreting that information and taking it in and integrating it that is so key. So we have all of these other layers in the central potential causes of dizziness. So when we meet somebody, when they're telling us their story, we start this sorting process, and that is where this cool article comes in. So this is let me pull up the name of the article and I'll put a link in here too. Strobel is the first author. Here it is. A set of 8 key questions helps to classify common vestibular disorders. This came out in Frontiers in Neurology, Neuroetology, and April 2021, so hot off the presses. What I like about this are a few things, but first, one of the things that they found in this registry, you know what was most common of all the types of disorders that can cause dizziness? It was 3PD. It was functional dizziness. Not really a big surprise. That is what we're seeing the most of in our clinic, to be honest. So that's the most common, then vestibular migraines, and then some of these other vestibular disorders. What I love about this is they went through and found key questions, 8 key questions actually, that when they asked these, they could correctly diagnose 50% of the diagnoses and sort through the different diagnoses with the questions. So we're 50% there, and honestly, our clinical exam gets us the other 50%. But great questions, so simple. So they start at the top with simple yes, no. By the way, huge shout out to Vestibular First, Lena Esmond, who posted this article and keyed me onto it. This is why I love keeping in touch with colleagues, because they read cool things and then I see them and then read them. So, by the way, we use their goggles, Vestibular First goggles, a key part of our clinical exam, and she invented them. They're awesome. She's a PT, vestibular PT. So, heading back to these questions, this is our first pass. We've got attack duration. Is it greater or less than 2 minutes? We know that's really significant, especially if that attack comes with turning in bed. That's a cardinal sign of BPPV. And that differentiated, so this first little piece here, that differentiated 50% of the people with BPPV. Or is it not with turning in bed, but instead walking in the dark? And that is where a person, especially with a bilateral vestibular hypofunction, unilateral can happen too. That's where we can see that occurring. Other key questions, hearing problems, because that takes us down the pathway of a potential Meniere's disease or vestibular labyrinthitis. Age can help us distinguish between different diagnoses as well, less than 60, greater than 60. The presence of vomiting. So vomiting with a rotational vertigo too, that can be a unilateral vestibular hypofunction, but also can be a key sign of vestibular migraine. And the movement or activities as a trigger, another big piece of vestibular migraine or a unilateral vestibular hypofunction. So anyway, I'll put the link in here because I really love this article sorting through those first questions that help us distinguish between these types of dizziness. And that gets us halfway there. So that's great. That'll get us halfway there. Our clinical exam gets us the other half of the way there. And our clinical exam also takes us to that next step of getting to the underlying anatomy. So I'm not going to go through the whole clinical exam, but I'll just give you a couple of examples. So for example, if we've identified through our questions that this sounds like it could be a unilateral vestibular hypofunction, like a neuritis, like an infection. I had an ear infection that caused this once. So in our clinical exam, we are going to test the integrity of the vestibular nerve, in particular the VOR. And that's where we can test it with a head impulse test. We can test it with dynamic visual acuity. We can look at the presence of fixation or not and use our goggles and look for spontaneous nystagmus and head shaking nystagmus. And we can set up some pretty good evidence for a vestibular hypofunction. So that's an example. And then that tells us very specifically we've got a nerve dysfunction and we know precisely what to do. We know that responds very well to vestibular rehab. Awesome. Hallelujah, we can help somebody through a bout of vestibular hypofunction. So let's go another example. Let's say this person meets all of the criteria through our great questions of a functional dizziness of 3PD. So they're getting dizzy in the supermarket and with motion and with a change in posture, and they meet those criteria for 3PD. Well, we want to test out precisely what pieces are contributing to that. And something that I really learned from Jamie and Catherine, this was part of their free webinar they did with us on the otoliths, was we need to test for otolith sensitivity. Are the otoliths, that part of our inner ear that respond to gravity and acceleration, are they extra sensitive? And in particular, how does somebody respond to gravity? How does somebody respond to movement? and upright posture and posture writing responses. Can they respond well? Or is it extra hypersensitive, which occurs in a functional connectivity issue? Then we need to treat that portion of it, right? What we understand about functional dizziness or 3PD is that there are multiple connections that can go awry. Normally, our brain is weighing all of our sensory information coming in from our vestibular system, from our eyes, from our somatosensation, even our auditory system. It's weighing all the sensory information. And it's weighing it well. What occurs with functional dizziness is we get certain things weighed higher. So visual might be weighed higher. We need to up regulate the sensory system. So the otolith might be hypersensitive, and we need to rebalance that as well. So this is something that I really loved and learned from Jamie and Catherine and been incorporating more and more into my treatment. But we can't know that until we test it. So the otolith, for example, we have static and dynamic tests that we can do to look at the otolith function. One of the simplest ones that I love is just orientation to vertical, standing on an incline. So we test that, we test the visual, we test somatosensation, and then that can lead us right into treatment. So it's one thing to have that, definitive diagnosis of BPPV, of a vestibular hypofunction, of 3PD, or a vestibular migraine. It's one thing to have that diagnosis, but it's another to understand the contributions of the different systems to that. Is it a pure VOR issue? Is it an otolith issue? Is it a visual issue? Is it a somatosensory issue? Is it all of the above? Is it the neck too? So is it cervicogenic? We have tests that we can do to rule in or rule out, but also, as I see in complex dizziness, rule up in our dizziness pie chart, so to speak, or rule down in the list of things that are contributing to symptoms. And then that takes us right into treatment. So, for example, if it's cervicogenic, we test that. We can test neck proprioception. We can test with a head neck differentiation test. We can test with a response to traction. If that's all positive, we can be pretty certain it's cervicogenic, and then we can go right into treating the neck portion of the problem. As another example, if it's a functional dizziness or 3PD, we can assess those contributing systems. So we might find that there's an overweighting of the visual system and an underweighting of the sensory system and a high sensitivity or hypersensitivity in the otoliths. And then we can treat that. Now, the good news is for all of these, even cervicogenic, but really any of them, incorporating the autonomic nervous system into our treatment is a huge win because the autonomic nervous system interacts and regulates with the vestibular system in a highly attuned fashion. And so we can start treatment with giving somebody some of those resources to help control their symptoms through the autonomic nervous system, and then address all the other issues. So the visual issues, the otolith issues, the sensory issues, but we have to test them out. We have to test it all out to be able to go into treatment. So what did we just cover there? So first we went through differential diagnosis of some of the most common disorders that cause dizziness. We talked about how great clinical questions can get us down through an algorithm basically to help us discern between things like benign paroxysmal positional vertigo or vestibular hypofunction or Meniere's or vestibular migraine or 3PD. So we talked about those clinical questions. We talked a little bit about clinical exam to get to the underlying anatomy that is involved, the anatomy and physiology, because that takes us right into treatment and successful treatment. Like, these are disorders that people can get better and have full recovery. But we need to have that assessment and that differential diagnosis first. And then finally, like, why are we talking about all of this? Because we have our first 1 day live online course coming up. And in fact, at this point, we have 6 more spots left live because we're limiting the amount of people who join us live, but people can join us for the recorded course. It's called A Positive Spin on Dizziness. It's a very unique course that doesn't just go, what is the diagnosis, but it gets down to what's the underlying issue, anatomy and physiology, so that we can treat those underlying issues, especially in complex disorders where we have certain areas that are underweighted, we have other areas that are overweighted, we have sensitivities in different parts of our nervous system, and we need to recalibrate it. This is what Jamie and Catherine are so good at. I've learned so much from them. I'm so excited to host them for this course. I'll put a link in the comments here for you because we have it at an early bird rate through July 4th. That is 2 days away. So I'll put that in here so that you can grab a seat with us, join us for this positive spin course to where we can really go a whole nother level into the assessment and treatment of complex dizziness. I want to thank you so much for joining me today. And again, if you're not already part of our newsletter, sign on up because I'll be sending out this article, link to this article and all the other resources that we put together for this week on dizziness. So thank you so much again for joining me, and I will catch you next week.